As I'm one of the peds ortho surgeons here, and I have the pleasure of introducing Dr. Lawson Copley today. I was fortunate to train under Dr. Copley during my fellowship in Dallas, and so it's an honor to now have him here and share his expertise on musculoskeletal infections. So Dr. Copley is an orthopedic surgeon and director of the Musculoskeletal Infection Program at Children's Health in Dallas, as well as faculty at Texas Scottish Rite for Children. He started the MSI program after noticing how the medical care for patients with infections was not standardized and families would be shuffled around through multiple departments. Under his direction, the MSI program has adopted a family-centered model that brings the family together with the multidisciplinary team for open discussions about the patient's treatment. Dr. Copley graduated magna cum laude from Wheaton College and received his medical degree from Kansas University Medical Center. He completed both his internship in general surgery and his residence in orthopedic surgery at the University of Pennsylvania and completed his pediatric orthopedic fellowship at Texas Scottish Rite. Dr. Copley is a veteran of the United States Air Force and served as Chief of Surgical Services, 96 Medical Group, and continues to serve in the Air Force Reserves. Outside of his practice, Dr. Copley plays the guitar and piano and enjoys performing together with his 3 children who also play various musical instruments. So welcome, Dr. Copley. Thank you for coming.
Thanks, Melissa. Well, it's really an honor for me to be here, and it's a passion of mine to talk about this subject. I titled the talk, The Story of Pediatric Musculoskeletal Infection in Dallas. It's really our story, and I hope that you'll find things about your story that resonate with you. It's evolved over a 21-year period, and this article in Harvard Business Review caught my attention about a year ago about storytelling that drives bold change. And Adi Ignatius, who's the editor-in-chief of the Harvard Business Review, pointed out that there were 2 turning points in the 40 years that he's been involved in business that were revolutionary. The first was the introduction of PowerPoint in 1987, which has become the syntax of corporate communication. Obviously, we use it still today. And then the next was the introduction of the TED Talk as a refreshing alternative to corporate speak. These brief presentations can go viral and literally reach audiences of millions within a couple of months. And so what is it about storytelling? Well, humans think in metaphors and learn through stories. And the important parts of storytelling include honoring the past, understanding the topic deeply, and then describing it simply, and providing a clear and compelling mandate for change, and describing a rigorous and optimistic way forward. So I hope to accomplish some of that with you today. So Children's Medical Center in the era of 1960 to 1980 published their experience, and that's really what I walked into in around 2003, was this history from Marianne Jackson and John Nelson, 471 cases of septic arthritis over about 26 years, or about 18 cases per year, and 258 cases of osteomyelitis over 22 years, or 11.7 cases per year. And so the literature up till that time talked about osteomyelitis and septic arthritis as a potential with overlap of an inclusion of about 15 to 20% that had both. Those were considered the sequela-prone child, the one where the joint ultimately gets destroyed and leads to bad outcomes. And for those of you who don't recognize this form of communication, this is what they call a handwritten letter, dated in 2008. I treasure it because it comes from John Nelson. And I had just given a presentation to the infectious disease group at Children's, and he was present, and he shared with me his story, what he had experienced when he took that role. And so he said that all of the primary pediatric orthopedic infections were being admitted to the orthopedic team. And then his service, the pediatric service, were dealing with these chronic, recurrent residual infections. But when he really studied it, he realized that all of those patients had previously been patients that had been on the orthopedic service. They just had wrong dosages. They were PRN'd at the end of hospitalization, sent to their pediatricians, And so the care was never completed. And so when he took over and he started monitoring aggressive culture acquisition, serum concentrations of antibiotics, then the clinical results changed. And the relationship that he developed with the orthopedic staff thrived, and the patients and families did great. So you could see that that was some of the passion that I was bringing, because what I walked into in that first 3 years was 554 children getting hospitalized 591 times on 6 different services to 10 different hospital units. And with all of those different points of view, no one was really describing the same entity. And on top of that, there was this epidemiologic phenomenon of an influx of musculoskeletal infection to our region, to our community, that people were unaware of. How did this emerge? Because these were different data than what had been reported by John Nelson and Marianne Jackson. There was a 600% increase in osteomyelitis in our community, but if you look at the population density increase, it was about a 200% increase in population. It explains why septic arthritis seemed to grow organically. And then we were also discussing new things like pyomyositis and abscesses that required surgical intervention by an orthopedic provider in the operating room. So I call that period every child for themselves, because it was as if we were doing the case for the first time, every time, as if we had no guidelines or no good guidance. And that leads to very inefficient and ineffective processes of care. It was taking us 2.5 days on average to get an MRI of these children. And our length of stay was nearly 2 weeks for osteomyelitis, 11% readmission rate, and the families were very unhappy with the experience, to say the least. And so were the providers. I had long conversations with the hospitalists at the time, and they were saying, can we do something? Can we collectively do something to help improve the experience for these cases? When you have that type of variation, you end up with something like this. So in a 3-year period, for 212 children with osteomyelitis, these are the antibiotics that were used up front. There's over 30 antibiotics on this list. And then you see a frequency distribution of the most commonly used antibiotics. And at that point in time, we had no clindamycin-resistant MRSA in our community. We have some now, but the empiric antibiotic of choice should have been clindamycin for any of these disease entities on the basis of the MRSA distribution. But we were using vancomycin as our first drug of choice, and it was used in 180 children out of the 212. So anyway, the empiric antibiotic was used only 13% of the time. And these are easy things to fix when people are aware of them. But no one is aware of these things unless you present the data to them. So it was a multidisciplinary stakeholder team that sat and listened to just the basic low-hanging fruit of how we could improve. And that was the team that compelled us to change. And why do we see so much in the South? I know that you experience a lot of musculoskeletal infection here. This is the HCUP-NET kid inpatient data, which shows the discharges for deep infections. And we lead the way. I trained in the Northeast and then came to the South to practice. I tell our fellows, train in the South and then go to the Northeast, because you won't see as much of this. The New England area is only 1.7% of the hospital discharges for musculoskeletal infection. So our 20-year experience is about 1,400 cases of osteomyelitis in children, and about a 16% rate with contiguous septic arthritis. And then about 500 kids with primary septic arthritis. So what I think has evolved for us is this being grounded in experience, having so much volume and concentrating it within a limited number of individuals who are really at the core of this multidisciplinary effort. Because if you share it with a lot of different players who come to the table, their experience varies just enough that you don't make as much headway. So being grounded in experience, which is what Antaeus required, and this is Hercules crushing Antaeus because they lifted him from his connection to his Mother Earth. It's pathomata mathemata, learning through trial and error and repeatedly gaining from the experience that we accumulate. This is a snapshot of that, and it shows 1,100 deep infections on a denominator of 3,500 cases. So that means that over 2,000 cases, 2 out of every 3 patients that I evaluate for the concern of musculoskeletal infection don't have musculoskeletal infection. They have this laundry list and eye chart of all these different things. It's over 80 unique diagnoses from the sublime to the ridiculous. And it includes some very serious things. Ewing sarcoma, leukemia, hemophilia, JIA, things that require an intensive inpatient evaluation to get them on the right track. And then it includes a lot of viral or self-limited disorders like transient synovitis. And my world is really to focus on musculoskeletal infection, but I work within a Venn diagram, working with other entities. And the most interesting cases are at the overlap between rheumatology, hematology, oncology, and myself, where we're all at the bedside together, and we're scratching our heads, and everyone is saying, well, it really isn't us. It doesn't seem like our effort. And I always say, well, when that happens, it's always rheumatology. I call this the Olympics of judgment under uncertainty. It's a really important thing to have that type of multidisciplinary dialogue that is collegial and interactive, especially with the uncertainty that is involved in these cases. This is our overall timeline. We had that multidisciplinary stakeholder meeting where I shared all of our data, looking at the epidemiology of the disease. And then I wrote guidelines, and they were reviewed by all of the key stakeholders. And we did an extensive literature review, and we finally put them into practice. January 1st of 2009 to December 31st of 2009. And for 1 year, I came into the hospital every day and met with the teams taking care of these children. We instead of having 10 hospital units, we narrowed it down to 2. And instead of having 6 different services, we narrowed it down to 2. And that was a game changer. It was a lot of resistance to that idea. It was no good. The shot's no good, Maverick. We can't meet at this time. And then when that resistance faded with what we call sustained determination, just a constant smile and an uplifting message. This is the right thing for the children. It is the right way to do this type of care. And we understand the guidelines, and this is what we're doing, and this is how we need to change it. It was revolutionary. And then we revisited it. We developed the Joint Commission Disease-Specific Care Program, then went into an era of patient and family-centered care, bringing the families directly into a conference room with our team. We did that up until COVID messed it all up for us. But we still do a version of it where it's now multiple teams going in, and we all speak the same language, and we all calm the patients and families down from a very anxious moment when they first come in. So these are our guidelines. It's a very extensive document. It takes about 6 clicks to get there in the computer system at Children's. They might as well be on outer space if that's what it takes, if it takes more than 1 or 2 clicks. But I know the guidelines by heart, and I'm always the one to re-educate our staff. And it is a lifetime commitment to constant re-education, because there are over 900 staff members of the institution that may touch our families because they're involved in all the staff of all the different entities that they might experience. And so that's what I do. There's a National Bone and Joint Infection Guideline Panel. It was at 19 tertiary centers in North America, the Pediatric Infectious Disease Society and the Infectious Disease Society of America. I was very committed to be on that panel with a bunch of infectious disease experts, as well as some hospitalists and emergency room providers. And it was a labor of love. It took 12 years to develop these guidelines and get them published, first for primary bone infections and then for primary joint space infections. And so there's a deep footprint of what our experience at Children's has been placed within these guidelines. And I think that as far as you can go with a national guideline, because the experience is very different from one community to another, these are a good place to start. So the new paradigm that we've been championing is institutional processes, workflows, and guidelines that support consistency of evaluation and treatment. And this multidisciplinary team approach with multiple perspectives, collegial discussions, the wisdom of crowds permeates. And so the structured systematic approach, some pattern recognition, and minimizing the use of prediction rules, the basic physical findings, history, labs, radiology. I consider this very important first step. We localize the problem and get some degree of context. We establish a level of concern, and there are parameters within these lab values that help us categorize severity or recognize other conditions that are not infection, and then focus on the locations of concern with our plain x-rays and use some ultrasound for the hip evaluation or pelvis region, looking for hip effusions. Abscess identification is better seen, in my opinion, with ultrasound if it's the skin and skin structures rather than with MRI, and then DVT whenever indicated. And then system one thinking is when we get to use our intuition, and we have to, because all of the data gathering that we have will still leave us short. This is an uncertain endeavor, and we have to embrace that uncertainty, and then finally use that for when we're really worried about this child, that they either have a deep infection or they have another condition that may be worrisome enough that it requires that multidisciplinary stakeholder approach, get them in the hospital. And when we're not worried, I try and externalize those patients from the hospital system and bring them to my outpatient clinic. I try and get them out of the ER without getting them admitted and make sure that I'm the second look so that something bad doesn't unfold. And that generally works. The really worried kids, they're usually not as uncertain as the rest, because they come in teetering on septic shock or evolving toward that rapidly. They go to the ICU, it's resuscitation time and broad spectrum antibiotics per our guideline. And then the decision for MRI, well, that's at the end. Our MRI workflow improved everything, because from 2.5 days on average to get an MRI, we now get as many as 2 or 3 in a day within that 24-hour period following triage. We get them when we want them, and we do them in such a way that we can orchestrate additional care if necessary. And so we make a decision, do they need an MRI or not? And not every child needs an MRI. We can make the diagnosis that's right in front of us in many cases. And if they do, then we determine, do they need sedation or not? Because if they do, then we want to be there at the time when the imaging is done so that we can make surgical decisions and then proceed from that information under the same anesthesia that they have to get their scan. So this Cortices group is pediatric orthopedic PIs at 20 centers now in the United States. And I consider this a noise audit. When we look at all the variation that happens across these tertiary centers. And so this was just the question about aspiration practice for the evaluation of pediatric septic arthritis. And the greatest differences were noted in centers for the evaluation of the septic hip. And it was all over the map in terms of whether an MRI would be obtained, whether the center had any protected MRI time. And 72% of these centers have no orchestrated MRI plan. And so that's really says a lot about how we do things now. And the urgency of the aspiration process and who should do it, whether it's a resident or in the emergency room or with IR or with the fluoro suite or the orthopedic staff person in the operating room, all over the map, but also when it should be done. And I would say these are within triage time, trying to do this within 1 or 2 or 4 hours of triage, and then making good decisions on that information without letting the story unfold a little bit is a mistake. I'm the outlier here. I would go greater than 24 hours just because of what I know about primary septic arthritis and what I hope to teach you today from our experience. So Daniel Kahneman is a Nobel laureate for the Judgment Under Uncertainty, the work that he did with Amos Tversky, which was published in Economics. And he wrote this book, Noise. Wherever there's judgment, there's noise, more of it than you think. And wherever there is predictive judgment, and that's what we do with musculoskeletal infection evaluations, We're trying to make a predictive judgment from uncertain information up front. Do they have an infection or do they not? Wherever that exists, there is ignorance, and he's referring to objective ignorance, because all that we can gather up to that point of time where we're making decisions has inaccuracies, and we have to embrace those inaccuracies and know where the uncertainty comes from. This shows what has happened in our institution. We did a 6-year time span, and we broke it into 2-year increments for the MRI process. And we can see that over the course of time, when we started, the average MRI scan duration was 110 minutes, almost 2 hours. And we used contrast 100% of the time. And every 2 years, we were paring that down to the last 2 years, which was 34.9 minutes. But in the last 6 months of that, it was only 24 minutes, and the contrast use dropped to 8%. Now it's about 10 minutes on average, but I can get children through the scanner in 5 minutes if I'm there. And it's a limited number of sequences. The traditional MRI protocol is multiple sequences with and without contrast. We felt that the contrast was indispensable because how else would you see these abscesses that are there? But they look exactly the same without contrast. You can draw a line around them in the same way that you can with the contrast. And so there's concerns about the use of contrast. This was 10 sequences with and without contrast, 120 minutes. The FDA is giving some warnings that we shouldn't be using as much as we do. It's retained in the brain and the orbits for a lifetime. And in some kids with neurodevelopmental disorders who get multiple brain MRIs with and without contrast, there are some class action suits emerging. So the ideal MRI protocol, which is what we follow, we order it without contrast. If we really feel we need it, we can do a point of care creatinine. And then we just do 3 key sequences: an extended field of view coronal stir. And then we use the same field of view for the T1. In this case, the child had proximal leg tenderness. And then very clearly early on, I see that it's the proximal fibula that has the osteomyelitis. And there is fluid around it, but I can't tell how much. And so when we do our axial imaging, rather than go the entire distance from the bottom to the top of this field of view, we simply focus on the area of interest, and it cuts down the number of images in that axial scan. And here we have tented fluid underneath the periosteum of the proximal fibula, and enough that would require surgical intervention. And we took this child directly to the operating room under the same anesthetic. So septic arthritis, in my opinion, is a story of judgment under uncertainty. And these are younger children when we finally end up with recognizing the population who has primary septic arthritis. They don't like you to move their joint, and there is fluid in the joint, and they don't want to use it or bear weight on it. And it's a spectrum of clinical isolates. Staph aureus is part of the story, but it's not the same as with osteomyelitis, where it's 91% of culture positive strains, only 32% in this, and a lower incidence of MRSA. But the rest is age-based distribution, and I'll talk about that in a second. And we see a low rate of bacteremia or subsequent positive blood cultures. If I see a child with Staph aureus culture positivity and bacteremia, and they have another positive blood culture, I no longer think of that child as likely to be primary septic arthritis. They probably have osteo. We just don't know it yet. And it's hard to grow bacteria from joint fluid. We have to use supplemental technologies. So we were using 16S PCR for a long time, tried to develop it in-house, and we were unable to because of the lack of a sterile reagent to use. And so we switched to BioFire. 16S was taking 2 to 2.5 weeks to get the results back. BioFire is available within 3 hours. We look for about 30 specific pathogens with that, and it includes all the usual suspects. And the new guidelines recommend 10 to 14 days of antibiotic duration for primary septic arthritis. Well, if you treat osteomyelitis with that, you'll have residual and recurrent infection or chronic infection. So it's important to get that component right. If you're uncertain, just extend it to 3 weeks, and that's what I do. And these kids do extremely well. In our long-term outcomes study of osteomyelitis, we saw that there were some sequela-prone children with long-term adverse clinical outcomes. As I was doing that study, I was also following kids with septic arthritis for a longer period of time than I do currently. And I saw they were all doing great. So I stopped following them that long and I started PRNing them as soon as the antibiotic course was done. And so in our retrospective primary septic arthritis study, there was only one child out of 268 or 0.37% that had avascular necrosis of the proximal femur. That kid had a 2-portal arthroscopy, and the medial portal, I think, can be associated with AVN. They also had Staph aureus culture positivity on 2 separate trips to the operating room. No blood culture positivity, but when I really study the initial plain radiographs, I think I see some metaphyseal lucencies close to the physis. I think that child had osteomyelitis and contiguous septic arthritis, which would make this almost a 0% phenomenon. We're now studying kids with septic arthritis, and I'm following them for 1 year and bringing them back for that outcome with POD-C and PED-squal and x-rays, and we'll see how it works out. Here's the age distribution of primary septic arthritis. In the birth to 6-month age group, 90% are group B strep and the Enterobacteriaceae passed in the peripartum period. In the 6-month to 48-month age group, 90% are Kingella and Staph and Pneumococcus, with a few other fringe players after that. In the 9 to 12 age group, it's pretty much Staph and strep, and you throw in GC and chlamydia, but mostly GC. We use the urine GC DNA amplification test. It's the truth serum. They seem to forget about their sexual activity until that result comes back, and then they remember it. And then this interesting age group, which is when we see post-streptococcal reactive arthritis, transient synovitis, and it's a wide range of organisms with no real hero of the story. About 33% staph, 25% strep, and then the rest is a laundry list. So we really rely on the PCR technology from 6 months to about 9 years. It's pretty vital. So this is a 3-year-old female that woke up from a nap with hip pain, inability to bear weight, subjective fever at home. It was grossly irritable on exam with rigid guarding. And we have enough information, CRP3, sed rate 35, white count with some bands, negative blood culture, x-ray showed no obvious osseous abnormality, and the hip fusion on ultrasound. So this is where the noise comes in, what different people do with this type of case. But to me, everything lines up. I'm worried about this child. They're in the correct age group. I think that this is primary septic arthritis until proven otherwise. And this is what we do. I go to the OR and I now scope all the hips. I used to open them all with that big incision. And so I leave a little space where I can put the aspirating needle. I show this because sometimes people have challenges getting this fluid out despite knowing that it's there. And these are the types of things that you may encounter. So I know this needle is in the joint. I put it there, and now I'm spinning the needle. I'm going to tap it up and down inside the joint capsule. I'm flexing and extending the hip a little bit to make some space. And I'm waiting for a flash of fluid before I hook up this syringe and try and suck all the blood out of the synovium. And I will finally see the little flash of fluid in the hub of the needle. There it is. Now I hook up the syringe, and I'm going to attempt to aspirate this fluid. And it may not come easy. So put a little suction on. And the first law of orthopedics is if force doesn't work, use more force. So I put a little more suction on, and here it comes. It's gross, thick pus. Can't read print through it. We're there for the right reason. And I know we have a poster on the wall to help everybody else know what we're sending this for and how much should be aliquoted in each thing, because I need a minimum of 1 milliliter from any joint, and I can get everything that I need. I get aerobic culture, a PCR, and a cell count. And I don't wait on that cell count. I used to, and then I found that it was absurd, because there's such a range of cell counts that you get with or without infection that shouldn't guide my judgment or my decision making. That's where the aspirating needle goes. Then I inflate the joint with plenty of fluid, and we pass a larger needle toward the teardrop of the acetabulum. It's like a 14 gauge needle that allows us to insert a nitinol wire. This is inside the joint capsule, perpendicular to the neck toward the teardrop of the acetabulum. And then we drive this scope sheath right over, it's cannulated scope sheath. So a tiny little incision on the lateral border of that which I had drawn out, and push it into the joint. And this is the best view that you'll get of a pediatric septic arthritis case. I opened them all for 20 years. I never saw this, or so seldom did. It was anatomy, blood. Is it the capsule? Am I in or am I not? We succeed at the end of the day, but the reality is this is a beautiful view of the articular surface, the labrum, the inflamed synovium. This one did have a two-portal approach because there's the drain that got inserted, but I just use a single portal. I don't find a lot of fibrinous aggregate that requires a shaver. If I do now, I would triangulate from a separate lateral approach. And this is a little 4 millimeter incision. I call it a 4 millimeter joint aspiration. And these kids do so well that it's the way to go. So here's the judgment under uncertainty part. In 11 years, we have a registry where we continuously track all the children in our system that come in with a concern for musculoskeletal infection and those that are confirmed to have it. And we do that because you can never go back and find your patients afterwards. If you reach out to HIM and ask them, give them a list of ICD-9 or 10 codes, and you will get a list of meaningless information and way too many charts of patients that don't have the condition you're looking for. So our registry is very helpful. But when we look back at 355 kids, we found that 10% had other conditions, viral inflammatory reactive conditions like JIA, lupus, post-streptococcal reactive arthritis, and transient synovitis. And so it shows the vulnerability that we have when we rush these kids to a procedure when we don't yet know what they have. And so the fact that we ultimately boiled this down to 134 confirmed and 134 presumed cases, it shows us still what we're up against, because I do believe in this presumed cohort, there's some of those other things. We treated them like infection. They resolved like infection. They never came back. They didn't end up in rheumatology clinic. And they were probably primary septic arthritis to the best of our ability to know it. Of course, the Coker criteria, historically renowned and still talked about today and quoted. It was introduced in 1999. If you know these 4 things, it's supposed to tell you all of this and give you a great sense of certainty. It just doesn't work that way in reality in clinical practice. And even when you add the cared modification of the CRP, it's not as helpful as we'd like it to be. I've had plenty of kids with 0 risk factors that had septic arthritis, and I've had plenty of kids with all 4 risk factors that definitely did not. And those are what I call the black swan cases. Well, why the Coker criteria has it survived so long if it's not as useful clinically? Because people like it. It's comfortable. The Lindy Cafe is right across from the theater district in New York City, and the actors would take their lunches there and they would watch the playbill, and they would see if something was there for a long enough period of time, they knew that it was going to last much, much longer than that period of time. It's called the Lindy effect. And I think that's the effect that we see from the Coker criteria. It's a comfort thing. It's the easy button. It allows us to know just a few things when we really need to know so much more. And I don't want to be a Grinch about it, but rule-based algorithms will often let you down. And I teach this to our residents and fellows. It's like the saying, when I die, I want all the people that I know and worked with to be my pallbearers so they can let me down one last time. And that's all I'll say about the Coker criteria. I have tremendous respect for Min Coker, by the way. And of course, the Coker criteria have done really well historically in terms of longevity. So this is where we talk about objective ignorance. When we take all of the things that make up this comprisal of the Coker criteria, we see that there's a lot of inaccuracy at the end of the day of, did this predict a deep infection or not? And the inability to bear weight is less than a coin toss. It's like the roulette wheel in Vegas, where you have the 2 green numbers that make it 48%. And so we did throw in procalcitonin just to see if this was going to add additional detail. And with new cutoffs, not to say if they're above these values, I'm more worried that it is an infection. What it really tells us, if it's below these values, I can trust it. I can trust a negative test. It's the negative predictive value of these things that is the highest of all of it. And so I definitely use that in my mental algorithm when I'm doing this systematic approach to evaluation. When I see it below those cutoffs, especially well below them, I am much more content. So here's the age distribution. You see septic arthritis leans toward the younger ages, especially that 6-month to 48-month group. And this is why I don't wait on cell counts, because I have a bunch of confirmed cases that had cell counts of less than 15,000, including 1,700, 1,900, 3,700, et cetera. The point is, if that ended up being infection by culture positivity or PCR positivity, then I won't say all bets are off, because in general, you'll have higher cell counts, but we shouldn't use that as our decision tool. We should proceed if we're worried about that child and wash out that joint. 2-year-old woke up from a nap with fever and hip pain, refusal to bear weight, normal CRP, normal SED rate, but she did have a high white count, met the criteria. She also was refusing to bear weight and had the appropriate level of fever. She had 3 out of the 4 COCA criteria. Hip ultrasound was a positive infusion. My partner, who was covering the trauma block that day, said, "What are you going to do?" And I said, "Well, if I examine the child and I'm worried about them, I'm going to aspirate the hip and then potentially scope it." And he said, "Well, why would you do that with transient synovitis?" I said, "Well, it's a 2-year-old, so it's this Kingella age group, and I see Kingella present with some fairly innocuous labs sometimes, so we're going." And we did, and the fellow at the time, who's now an attending, was with me. He was very much on the camp, this is transient synovitis, we shouldn't be doing this. When we drew the fluid out and it looked like gross pus and the cell count was 60,250, he dropped his head and he said, "You're messing with my worldview," because I didn't want this to be an infection. And I said, "Well, that's my job, is to mess with your worldview." So the issue is, I did go ahead and proceed and scope and wash out this hip. It was culture negative, PCR negative, and the child, a week or 2 later, started developing elbow pain, wrist pain, a variety of other arthralgias. And I sent her to rheumatology, and she was diagnosed with JIA. If you talk to enough pediatric rheumatologists, they will say that the hip is never the presenting joint for JIA in a child. In fact, Lynn Punaro, who I well respect, used that word never. But I've seen 5. So that's what I call a black swan. The true incidence of black swans in North America is 1 in 500,000. They do exist, but you might think that they don't if your only exposure has been to white swans. And that is the issue with these predictive rules. We have to be cautious. So on the horizon, what the future holds is this multi-omics approach. We're starting to do this with our genomics lab. And it's nice because we send a 16S sequencing, and this is amplification of 16S RNA. It's like what they do for Carius testing. And so they can do this, all of this within 2 to 3 days. The cytokine profile is looking for the innate immune cytokines. And then the autoantibody profile looks for autoimmune antibodies, and you can see the number of them that they test for, and then single cell transcriptomics. And so we were able to identify these kids that were highly probable, and they did have JIA within 2 to 3 days of that aspiration, rather than within weeks or months or sometimes years. So it's a very valuable approach. Now I'll change paths and talk about the story of acute hematogenous osteomyelitis. This is a story, in my opinion, of severity determination. Comes through the bloodstream in otherwise healthy children or adolescents, goes to the metaphyseal ends of long bones or equivalent sites, and they're otherwise healthy kids. We don't need to look for an immune defect. Minor trauma to the affected area happens in 65% of kids with severe and hypersevere disease. And we get about 60 to 70 cases per year still. They don't like it when you touch their bone, not in the metaphyseal area where it exists. They'll go through the ceiling tiles, and or you can push away from that area if you see some overlying erythema and you're not sure, is this cellulitis or is it actually emanating from the deep infection like the distal fibula, sometimes distal tibia. If you push on the mid shaft of the bone away from that area, they don't like that either. They tolerate a reasonable range of motion if they don't have contiguous septic arthritis. And this is a Staph aureus disease, 91% of culture positive cases. Bacteremia is the hallmark of osteomyelitis, 45% of all cases, but if it's culture positive Staph aureus disease, it's 73%. It's really a remarkable feat. Our record holder for consecutive days of bacteremia is 16. That was after 11 days of ECMO, being bacteremic the entire time, all on appropriate antibiotic therapy. So the subsequent positive blood culture rate is high. So that's why I say, if you see bacteremia, look for the osteomyelitis. DVTs, we should be thinking about them at the point of entry into the system. Whenever the child has a red hot swollen leg and they're going to the ICU, they probably have osteo, and it's probably Staph aureus. In our community, it's more likely to be MRSA than not, but it can occur with MSSA, CRP in the teens. It's a 60% rate. And so we should do those ultrasounds before we get the MRI and before we do the surgery, and put all of the dressings and drains in place that make it hard to procure a good ultrasound. A surgery may be indicated for source control. We talked a little bit about that last night, and I'm trying to hone in on what is the best indications and techniques to use for acute hematogenous osteomyelitis. The guidelines now recommend a minimum of 3 weeks, 20 days from the finished study group, but we will go as long as we need to resolve the infection. And in our practice, the hypersevere kids will get 3.5 months of antibiotics, because the end of therapy is based on a study that many people want to dismiss. But the only abnormality that I still have to guide therapy at the end of treatment is the SED rate. It's an otherwise normal looking child with negative physical exam findings, and everything else is long since resolved. But that's how we get to that duration. 11-year-old female twisted her ankle. There's your minor trauma. Sat at home for a week and a half while waiting for a acute orthopedic visit in the trauma clinic. Came in with elevated labs, had a fever at home that came and went. You can see the metaphyseal lucencies, the deep soft tissue swelling, the MRI showing the abscess, subperiosteal, and then extraperiosteal as it breaks out up in the mid to upper leg. I apologize that this video isn't working, but I'll tell you, I'll try it again. It's not going to work. This is the joint, the growth plate line, and here's the joint surface. And I'm just going to have them make an incision at the very terminal end of this, because I want to expose the bone to get over that metaphyseal cancellous bone. We go in, we inside the periosteum, a volume of pus comes out, and then we open the bone with a window about 2.5 centimeters long, about 1 centimeter wide, curette out all the cancellous bone, the metaphyseal cancellous bone that I can reach while sparing the physis, and then leave good drains. 1 limb inside the bone, 1 limb in the subperiosteal space, close like I'm never coming back, because that's my intention. And we try and get to that point where we can do less surgery. And I would do this for every focus of infection in a multifocal osteo case, as long as it was safe to do so. I don't enucleate the cancellous bone of the proximal femur or the calcaneus, because they're going to get pathologic fractures that will be devastating. I just drill decompress the proximal femur, and I use about a 7.3 millimeter cannulated drill. And then I just take a little slot of the posterior tuberosity just to open it up and take away pressure from that area. This is the same pathology of the child who I just showed you. It's a different patient. And it shows what happens when you have a tag team approach to care, and when the concept of understanding the disease process does not match what we really now know. So this was 5 surgeries done by 5 different surgeons, leading to this final picture. And we were still coming back, and this is not rational. It's not the diaphysis of the bone that has the infection. That little incision toward the end, all of that pus is contiguous and would have fed right down into that area and would have drained appropriately. Here's the metaphyseal cancellous bone, by the way, still there at the 5th surgery. And this child has these untidy diaphyseal openings and metadiaphyseal openings that lead to potential for pathologic fracture. That's what happened to this kid after they finally left the hospital 2 months later, and they had a path fracture that took 6 months to heal. So it just shows how we can improve, how we can optimize care with a better concept of disease. The severity of illness scoring, I think, gets us there. This was our original scoring model. It was modified and validated. It was a 10-point scale, 0 the most mild, 10 the most severe. And we used it for a lot of different things, helping recognize DVTs, helping to recognize the presence of contiguous osteo versus septic arthritis as a primary disease, and the rapid transition to oral therapy for children with bacteremia, and then our severity adjusted long-term outcomes with things like this: protrusio, chondrolysis, pathologic fracture, heterotopic ossification, disaster, requires total hip replacement at the age of 13. So for the severe conditions, the rate of long-term adverse outcomes, 32%. So the folks at Brown and Nationwide Children's developed a new scoring mechanism, the A score and the C score, and compared it to ours and showed that it performed better. There was a lot of missing data for ours. It's hard to tell whether it's truly that much different. They're all good. They're all capable of helping recognize severity. The challenge with some of these is the care is non-standardized between these centers, and there's non-standardized data collection, what we value and what we determine to be appropriate. The occurrence of a bone debridement and a delayed source control, the ICU admission that we use in ours, those elements rely a lot on human judgment and introduce a lot of variability to these scores. So we knew that we would probably need to do better if we're going to develop a tool for the future. And so that was our challenge. How soon is it possible to accurately identify severe osteomyelitis and predict complicated outcomes? And the nice thing about having a large registry is it allows us to really boil down. This is over just a 14-year period, but we ended up with 439 culture positive Staph aureus cases that we could develop this study model with and model this disease process in a way that has never been done before. So we had to have an outcome variable, and we chose to build that on the number of adverse events. There were 106 minor adverse events that resolved spontaneously or with minimal intervention, 19 different types in the cohort, and then 106 major adverse events of 40 different types. Those are those with permanent sequelae or that required substantial intervention to correct. And so there were a couple of unknowns with this, the AEI, the Adverse Events Index, and then this weight factor. How much worse is a major adverse event than a minor? So here's all our laundry list of the major. And when you talk about pathologic fractures, you get a lot of pathologic fractures that heal and remodel spontaneously. I mentioned last night, we have a lot. We do a lot of surgery on these kids. And so 27 just healed with almost no intervention or just minimal immobilization and didn't have any issues. But here's the bad outcomes that can happen with pathologic fractures. So with two unknowns, we had to develop this parameter space, the outcome space. And it led us to the recognition that in this group, to know who were truly complicated osteomyelitis, it was about 52 children. And that helped us to develop this scoring model, which I believe is the way of the future for this. Certainly is for us. The accelerated severity of illness score has a maximum of 39.7, and it's comprised of the odds ratios of all of these components. And 5 of these are present at triage. So within 6 hours, we know this information. And we have 2 of the remaining within about 20 or 16 hours of the time of admission. So this score will be available, and it helps us recognize the true propensity for complicated osteomyelitis. And this is how this score performs with very high AUC and outperforms all other scores. It has a wide dynamic range, so it characterizes the entire disease population, and it has a very low ceiling effect because you don't want all of your patients to max out and not really see where the true top is. Only 2 children out of those 438 had the maximum score. So if we run sequential ROC cutoffs, then we now break this population into 4 unique disease categories and add this new hypersevere category: mild, moderate, severe, and now hypersevere. And it is an exponential curve toward the propensity of complicated osteomyelitis, or having those adverse events accumulate to reach that cutoff. 0% of the mild kids and 82.5% of the hypersevere kids. So the old model was this, and now we have a new model, where we can really separate primary septic arthritis in our mind and then focus on osteomyelitis with or without. We learned that there is a big difference, many marked differences between a child with primary septic arthritis and those with contiguous septic arthritis, the age of the child, the presenting CRP value, the rate of bacteremia, and this one always gets me, 90% of kids with septic arthritis, even those with very low cell counts that don't really appear that concerning, you grow the bacteria from the joint fluid versus only 35%. And then, of course, the complication rate, and that 0.4% is probably zero. And now with the Excelsis, we can now substratify this population so we know the ones that we're really worried about. And this is where the indications and surgical techniques will come in, because we were doing bone debridement on 34% of kids with mild osteomyelitis, and in my opinion, we shouldn't be doing it at all, now that I know this. That what the occurrence of surgery does not equate to the need for surgery. And so this is simply showing you the occurrence of surgery for this study population, but we progressively increase the rate of bone debridement. We also progressively increase the occurrences of surgery per operated child. We certainly shouldn't be doing more than one surgery on children with mild or moderate illness. And if the only surgery we're doing is a bone debridement, we shouldn't be doing that at all, in my opinion. And now we're doing 2.8 surgeries per child of the hypersevere cases. And what I often see is a pattern where we maybe operate on one focus when they have 7. And we didn't recognize all of those foci in that initial evaluation. We need to image all of those areas, and we need to aggressively go after those. I do believe that bone debridement is still appropriate, even with the risk of pathologic fracture, especially for that population, as I see it truncate the duration of bacteremia, and I see it shorten the length of hospitalization, and it also has the institutional calm down factor that plays for it, because there is this institutional kind of panic button that gets hit, certainly at our center, for an ICU admitted child with multifocal osteomyelitis and dissemination. It leads to multiple antibiotics that are used empirically, and then even with targeted therapy, until you get good surgical source control and you see everything heading the right direction. Procalcitonin drops first, then CRP, then finally the SED rate will peak and fall. And that's the way it goes when we are really all working together. So I'm trying to get this number down to 2. There definitely are children that prove the point that they need an additional surgery, in my experience. But I wait a much longer period than I had historically. We used to go back, when I first started, we would take some of these kids back 5 or 6 times, and they would get MRIs 5 or 6 times. And my partner, who started the same day that I did, we're like a tag team. We jokingly said we should install a zipper rather than close these incisions, because we're coming back, as we did so frequently. So trying to get that number pared down to the minimum amount of surgery. That also helps the families, because it is a big upheaval when you take their child back 7 times, and there's a feeling of we're not winning. And we like to get to that feeling of winning, everybody involved. Thank you for your time and attention. There is some time for questions. Yes.
Switch to not contract MRI. Did you guys notice this study happened?
Yes. So the question is, when we switched from using contrast to not using contrast, did we feel like we were missing any abscesses? And in my experience, because I am now close to 0% using it, I find that not for the abscesses that we're really interested in. So I do see, and when we did this study, there were 526 MRIs, and I reviewed it along with a musculoskeletal infection radiologist. We were very focused on when contrast showed us something, and that we felt like we weren't seeing on non-contrasted imaging. That occurred for skin and subcutaneous infections, but an ultrasound, which happened to be done in almost all of those cases, showed it better. We could see that demarcation of complex fluid collection. We could almost give you a volume estimate of it from the ultrasound, where the MRI, even with contrast, we were like, I can't tell whether this is edema, what the boundary of that is. So it did show us abscess that we didn't see without contrast, but it was for a use that we probably wouldn't have even ordered an MRI in the first place. And then that also exists in the deeper soft tissues like the muscles. When you're looking at a pyomyositis case, what I will often see in those cases is something that I know is abscess. It's big enough to be abscess. I could give you the dimensions of it, but I believe there's more abscess there that the contrast would show me. And so again, it's not a game changer for me. I think people do have that. I don't want to give up this thing that I feel very comfortable with, and it's the use of contrast. So it's a good question. Any other questions in here? Yes.
So how do they pop? So I'm already on this. See a lot of blue question. Then the payments. So you get a lot of false positive, which is orange.
Repeat the question. Yes. So the question is, the other end of the spectrum is, do we see things that appear to be infection but are not infection? And we're going to the operating room. Yes. So that has not been a problem, but I can see how it might be. I think, again, a lot of the judgment and decision-making is based on multiple things. When we wrote that paper about the MRI experience, I put in that I like to use pre-MRI mental imaging. It was like a question or a comment that was made last night. If you're in India, don't order an X-ray unless you're prepared to tell me what the X-ray is going to look like. I think you shouldn't order an MRI unless you're prepared to state, in your opinion, what you think that MRI will look like. So I think that comes from all the additional information that we have, the history, the physical findings, the lab values. And so I find that we don't get it wrong as far as we're committed, we're doing something that we shouldn't be in there doing. The big bucket of the Venn diagram that I'm really grateful for that we don't get wrong very often is orthopedic oncology. I did fall into a Ewing's once, thinking it was maybe infection, but I was really puzzled over it, and I was thinking, I don't think this is infection. And I talked to the musculoskeletal radiologist who had read it, and he was like, no, it's definitely infection. Here are the features that tell me that. So we went, and the pathology came back Ewing's, and I'd always had that lingering suspicion, but fortunately we don't get that wrong very often. The tumor cases usually go into that big bucket. And if it's an in-betweener, I let the tumor surgeons do the biopsy and culture versus me. The ones that look like benign processes, I take the subacute osteos. Any other questions? Yes.
Just a couple questions. One, can you comment a little bit about IR in your facility? Because here it's much more likely that the patient would go from the ER to IR than actually to the OR with ortho. And then second question is, what percentage of all osteomyelitis and septic arthritis in your institution end up going to the OR with an orthopod?
Yeah, so I end up being the orthopod, in almost all cases, unless that's I'm out of town. And that's good, because it's when you have 17 people that could potentially touch something, you're going to have 17 different ways of doing it. Similarly, IR was in vogue before I got there, and then I kind of ended up having determined desire to be the one to take these cases so that I could learn from them. So it almost extinguished the use of IR because I was the one taking the cases and doing these procedures open or with limited open approaches. So then we had new IR staff join, and they wanted to get involved. And then we dealt with that workflow issue. Because I was there when the scan was being done, they were wanting me to then communicate to them, are you available to potentially take this kid? They're under anesthesia, can you go? And it didn't fit their workflow at all. They were doing our IR procedures, and so that didn't work. So I would end up taking them myself. So I do understand that some centers and some settings, interpelvic abscesses, it's great to have that and not to have to do a big open approach. So again, and I think for some of the spine questions, it's very hard to get IR to commit to doing a aspiration of a disc space. And understandably, but that technology does exist. It is possible. They can do it, but we don't ask for it. We just start empiric antibiotics and then watch for an early clinical response. We sometimes see a sluggish response in Kingella cases because you've started gram-positive coverage with Clinda and it's not touching the Kingella. Child's not getting well. And it's in that age group. So then we'll just switch, we'll add ceftriaxone and send them out on Bactrim. And they improve in front of our eyes. So I think we do a lot of workarounds that avoid the use of IR. Yes.
I'm from infectious diseases, so I have to comment about our microbiologic story and how it's different about the practice. Only 35% of our staff workers are actually MRSA. And this is why for us, the preferred starting antibiotic is Avastin and of course which obviously takes care of the Kingella question.
Yes.
The emphasis that I wanted to make is obviously related to the antibiotics and the site of infection and how that might affect the outcome. Because obviously, if we have someone who's in septic shock in the ICU with Staph aureus bacteria, the chances is that it's going to be MSSA. Our antibiotics are obviously more effective than vancomycin in most situations, including contamination with development. So we do have a slightly different story from that microbiology standpoint. And that obviously affects all the, the work that, is done from when the kid, goes to the ICU until they go home. But it's still, the emphasis is always going to be a source control and how important it is. And that's the emphasis that we try to make all the time, especially when someone is in a critical condition, about getting that done. So, again, long comment, but my question specifically is about, your choices of antibiotics and how that evolved over time, especially it sounds like the focus has been on, clindamycin being the first choice. Has there been any discussions about switching to something else to, to address that microbiologic, dilemma, especially when Kingella gets into that? Things?
Yes, thanks. So just to summarize the comment, there is an epidemiologic difference in the local microbiome that influences decisions about empiric antibiotic use. And your experience is about 25% MRSA versus 75% MSSA, and that drives cefazolin predominantly as empiric antibiotic. And our community, 40%, that's driving Clinda for non-ICU admitted kids. And then with ICU admitted kids, because everyone's uncomfortable not having a bactericidal drug on board at the outset, when you realize that you're dealing with potential evolution of sepsis, our guideline is vancomycin and ceftriaxone. Ceftriaxone to cover for potential gram-negative endotoxemia. Usually it's the one dose that's the only one that's given because the blood cultures start coming back fairly quickly with these kids. They're bacteremic, almost all of them. I think it's 90% of our ICU admitted kids are bacteremic. And the nice thing for us is now we have Veregene. Veregene allows us rapid determination of MSSA versus MRSA. And when we do see ICU admitted kids with MSSA, we immediately switch from vancomycin because it behaves like a static drug. It's so slowly bactericidal in the presence of MSSA. Doesn't get into inflamed bone well, doesn't kill intracellular organisms. It's the worst drug to use for treatment of osteomyelitis. So we try and get to a bactericidal drug. If there's concern about CNS involvement, it's nafcillin. Otherwise, Ancef is fine, cefazolin. So I agree. A lot of communities fail to recognize Kingella because they are actually treating with cefazolin Keflex and it's resolving the Kingella and they're not sending the PCRs and even identifying it. So there are important profound differences. That's why guidelines do need to be local and even institutional. The guidance that if about 15 to 20% of the organisms are resistant, then you ought to use an antibiotic. That's probably a little bit outdated because you're covering 75% of your population, and then you can pivot quickly. I think that ability to pivot quickly is still very important.
Can you advance one slide so we can get the Okay, so everybody, we can take a picture of the QR code and then you can do our one question evaluation. And let's thank you for Dr. Copley. Anybody else who wants to ask questions, feel free to come here. We got one on Zoom from somebody who knows you from before. But everybody, all the residents, you can get back to the Lord. Here's the one from Corey Pfeiffer. Corey Pfeiffer here, formerly from Dallas, in case you remember me. Is it difficult to get satellite hospitals to buy into a musculoskeletal infection protocol if the other hospital is partially staffed by a different group?
Yeah, and Corey, I remember you well. Yes, so we have a satellite hospital, and yes, it is difficult. It's practiced in a very different way that Plano Hospital. And so similar to anything, buy-in is difficult to attain. And when we go to, when I go and speak to that stakeholder group and I share with them this information, there is a tendency to change behaviors. The hospitalists there were insisting on contrast until I showed them these slides and told them we don't need it. And then they stopped their pattern of acquisition of contrast. But we now have a multi-center study at 6 different Texas centers looking at this MRI process. And as you might expect, it's all over the map, the different workflows and utilization of MRI at 6 centers in the same region where the infections are probably going to be fairly similar. So this is going to have to be an endeavor of continued improvement across the nation if we're going to make this a scalable concept and cut down on unnecessary scan duration, unnecessary use of contrast, and the ability to act on information at the time of imaging if the child is under anesthesia. Thanks, Corey.
We succeeded in letting the residents out, and I thank you.
Hi, good to see you.
How are you doing this?
Yeah, absolutely.
Yeah, good.